Stop recording. All right, welcome back. We're here again. I love the sound effects. We're going to talk about infection. Okay. There's my buddy again. Today we're going to talk, or actually for the second part, we're going to switch from inflammation to infection. We will talk about the nursing concept of infection as it relates to the musculoskeletal system. We're going to talk about osteomyelitis, osteoporosis, and Lyme disease. Hint, if you see this guy, you might want to remember what we were talking about. Infection. Infection is basically the invasion of your tissues by a microorganism. Pretty simple, right? It can impair a person's mobility and their ability to do their activities of daily living. And your role as a nurse is to prevent, detect, and treat infections. Now, did my little guy pop up for that one? Oh, he did. There he is. All righty. Might want to remember this one. Osteomyelitis. What is that? Basically, osteomyelitis is infection of the bone. When the infection creeps its way into the bone, it can happen in a very variety of ways. Sometimes it'll go through the body, but more often than not, if somebody has an open fracture where the bone actually pokes through the skin, it exposes the bone, the inner bone, to the atmosphere, to all of the pathogens we have floating around in our daily life. But the one that most commonly causes osteomyelitis is Staphylococcus aureus. Sometimes you'll see that abbreviated as SA. There are two types of osteomyelitis, acute and chronic, and we'll talk about those two. You might want to remember that. Important things to look out for osteomyelitis. Three big things to look for. They'll give away a bone infection. One is the pain or aching in the bone in the area. It's kind of hard to figure out sometimes when someone's actually had a fracture or a broken bone because you don't know if the pain is coming from the actual fracture or the infection. But you will also, they'll have pain with movement. Now, if there is no fracture, then this is extremely suspicious. But the infection causes swelling in the area of the bone. So when the muscles move over it, tissues move, it can get pain. But a big one is heat or tenderness and reddening over the area. If someone, whether or not they've had a fracture, say in the femur area, they start feeling an aching in their femur and you start to get red and heat over that area, one of the first things you'll want to think of is osteomyelitis. The treatment of it, or actually, first of all, the labs, it is a bacterial infection. So you will see an elevation in the WBCs and elevation in their SED rate. ESR is also called a SED rate. And usually the doctor will want you to run blood cultures. This is also called CNS, blood culture and sensitivity. That's to find out what type of bacteria is infecting the individual and what kind of antibiotics will work to defeat that antibiotic. Now, sometimes Staphylococcus aureus can become resistant. If it becomes resistant to the penicillins, it becomes methicillin-resistant Staphylococcus aureus, what we better know as MRSA. So that Staphylococcus aureus is a very, very common bacteria. X-rays are a very late diagnostic. Sometimes the infection of the bone will cause pockets, much like they do under your skin. When you get an infection, your immune system will rush white blood cells to the area to consume or defeat the bacteria. And as they die, they form a white substance called pus. Well, that pus can also form within the bone itself. It will cause pockets, and that can be excruciatingly painful. And of course, the only way to actually go in and aspirate those pockets is through a surgical procedure. Like any other bacterial infection, the way to defeat it is through IV antibiotics. Usually, if somebody in the hospital is diagnosed with osteomyelitis, it involves real heavy dosages of IV antibiotics. I mean, they really have to hit this one hard, especially if it's MRSA.
Bryce,
Yes.
what is ESR again, you said?
It's the SED rate.
SED rate. What's the E stand for again, Eileen? I forget what it's.
I do too, but it shows inflammation. That's what it mainly shows. So it's in the CBC, and it shows if you have an inflammation. It also kind of is, you look at the white cells and you look at the SED rate or the ESR, and that you kind of figure out if you got a problem going on.
Mike, it's the erythrocytes.
I couldn't remember what the E stood for. It's erythrocytes.
Mm-hmm.
Basically, the white blood cells, an accumulation of white blood cells, much like the WBC, but it measures the erythrocyte, and ESL stands for erythrocyte sedimentation rate. So in other words, it's a collection of erythrocytes. And the higher that is, much like the WBC, the more erythrocytes you have in there, it indicates an infection.
So if a person has a high ESR but a low white blood cell, then it could be inflammation rather than infection?
It could be either. Sometimes a white blood cell count could be that your white blood cells aren't working, as in leukemia. So it could, just one being high and one being low doesn't tell you all one thing at once there.
Okay, thank you.
Especially if you're dealing with a viral infection.
And then you said that if there's like pus in the bone, you have to take it out. Would that be called a periocentesis?
Periocentesis, that's something different.
Okay.
It could be a bone aspiration.
Yeah.
Periocentesis is taking fluid from the peritoneal area. That's when if someone has a bad liver, they'll get an accumulation of fluid around their belly called ascites. I'm sure many of you have probably seen that before.
Oh, yeah, yeah.
Paracentesis, they just basically poke a needle in the belly and they can pull, 7, 8, 9 liters of fluid out of their belly, depending on how much ascites they have.
Thank you.
But it would be a bone aspiration, what they would use to get the pus out of the pocket in the bone.
I have a question.
Go for it.
With the ESR, you know how it's an elevated sedimentation rate? Would that also make them like small red blood cells because they're elevated? Are they able to be mature red blood cells?
I don't know if it measures that. I think when they see a high SED rate, then they look at the rest of the CBC. So, that in itself doesn't tell everything, but it makes you look, what are the red blood cells doing?
So what does that mean? If there's a lot of them in an infection, what does that mean?
Well, what it means, you keep on looking, it means that you got an overflow of those red blood cells, because usually your little capillaries have broken open. We know exactly what's happening. We don't know. We know there's a problem by seeing that. And then you'd have to look at the, like your other types of red blood cells. Are the immature ones working hard? Are the old ones dying off? You look at the whole picture, just not one thing, period.
They, with an ESR, what they're doing is they're putting the erythrocytes, the red blood cells, in a tube, and they're watching them descend over an hour. And that's why they call the rate at which the red blood cells settle. And that's why it's called the sedimentation rate. And how fast those red blood cells descend indicates things about the red blood cells. A high ESR rate could mean a variety of things. Anemia is one of those things. I think it's also in pregnancy and aging. The ESR goes up. So it's not necessarily just a sign. If it gets exceedingly high, then it's usually a sign of inflammation and or infection. But you kind of have to look at the specifics of, you know, what you're looking for to see if the ESR is going to tip you off as for what you're looking for, like say an anemia or something of that nature. It could be an indicator, but it's not a concise diagnostic test for any one particular thing. That makes sense?
Yes, thank you.
Any other questions? I'm going to cover nurse management here, and then we'll just open it up for anything on osteomyelitis. Usually immobilization of the affected bone. It'd be very painful for that when that bone moves around. Administer medications, especially antibiotics, and supportive care, analgesics and IV fluids. Because of the painful nature of the osteomyelitis. I'm going to shoot back here for just a moment real quick because I believe, okay, I meant to do another slide that went into acute versus chronic. There are some diseases that will cause osteomyelitis, but they are very rare. Usually it's the acute case where somebody has gotten an infection and it moves to the bone. I thought I had another slide in here explain that, but I missed that. My apologies. But acute, the acute case of osteomyelitis is the most common. Okay. Any more questions on that before we move on to osteoporosis? Basically, it's just infection of the bone. Now, some people forget that, you know, bones are dynamic living organs within the body. They have a blood flow, they have circulation. You know, the osteoblasts are building tissue, the osteoclasts are breaking the tissue down. You cut up blood supply to the bone, you can have necrosis and the bone tissue can die, and then the bone will actually degenerate. So you have to think of bones as an actual living organ within the body. Speaking of which, osteoporosis, a great segue. Osteoporosis is degradation of the bone tissue, which can be caused by a variety of things. Most of us are used to osteoporosis when we talk about older people, usually more prominent in women than it is in men. But basically, a real simple way of looking at it is your bones are constantly generating osteocytes, which are the solid bone tissue of the bone, and the osteoclasts are breaking those down. If the building process gets slower than the breaking down process, then you're in trouble because you're not renewing your osteocytes quick enough. The bone begins to degenerate, the bone gets weak, and that's when you have people stepping off curbs and breaking their hip, or what's very common in older people, falling down and shattering and breaking their wrists. Several things can cause this, but basically it's a loss of calcium and phosphate salts in the bones, the material with which you build bones, that causes this. And there's a variety of reasons that this happens. There's two basic types of osteoporosis. So there's the primary and the secondary. Primary is the one that we're most familiar with. in postmenopausal women, and it's aggravated by a lower intake of calcium, or maybe not necessarily an intake of calcium, but a lower metabolization of that calcium into the materials necessary to build bones. As we covered back when I think last year or last quarter, when we were talking about the production of cells within the bone marrow, the erythrocytes, the leukocytes, etc. I remember in the production of calcium, you also need vitamin D to help that process into the bone material. But also estrogen levels, as women go through menopause, the estrogen level drops, which contributes to the lack of calcium being processed into bone material, and just a sedentary lifestyle. Much like muscles, bones respond well to stress. If you sit on the couch and do nothing, your muscles will atrophy and basically shrink up, and they don't work as well. You have to get out and actually use those muscles and build those muscles in order for the muscles to continue, which is why we all exercise. The same is true of bones. Not putting stress on the bones can eventually lead to degradation of the bone itself. Which if you watch the crash course, you will see, you know, having negative gravity in space can adversely affect your bones and could actually lead to a form of osteoporosis. We got a couple of questions in chat. Let me bring those up.
Oh, they're just me being funny.
As Eileen points out, your thyroid, calcitonin and parathyroid hormone also play a big contributing factor in osteoporosis, which also brings up a good point, Eileen. Another common dysfunction that comes with aging, especially in women, is hypothyroid. So
Right.
calcitonin, you have problems there also with building bone tissue, and also with kidney failure. The erythropoietin is a hormone that's necessary in the production of bones. It's the hormone that actually helps your body to produce bone. It's produced by the kidney. So when the kidney fails, you don't get as much erythropoietin in your system. And we give patients on kidney dialysis the erythropoietin shots. But osteoporosis can be only yet one other side effect of kidney failure. There are many. Just besides losing the ability to urinate, osteoporosis is one problem that can occur in people with kidney failure.
Bryce,
Yes.
you said hypothyroid affects bone breakdown?
Well, actually, no, he's kind of right there. When your thyroid doesn't work, it's not the thyroid hormone itself. Your thyroid also produces calcitonin.
Yes.
So that's where the problem is. And sometimes people's calcitonin's working just fine, but the thyroid's slow. But sometimes the whole thyroid is a problem. So you have to worry about calcium too. And we'll get into that. Don't worry about that right now, but we'll get into that in about another week.
Okay.
Notice calcitonin, calcium. There's a reason that calcitonin has that name. Just for future reference. Like I said, we're not going to talk about that now. But the primary osteoporosis is the one you most commonly will run into. There's also a secondary osteoporosis, and this is when we actually interfere with the process of bone construction. Some of the things that can cause that is corticosteroids. Now, I remember in our last lecture, we talked about how great corticosteroids are, prednisone and solumedrol for helping reduce inflammation. Well, this is one of those bad side effects that I was talking about. It can lead to things like Dowager's hump and such, which I'll talk about here shortly. Malnutrition is a problem if you're not getting the proper calcium in your diet. Scurvy, which we don't worry a whole lot about today. Scurvy was a disease very common with old sailors because they couldn't keep fresh vegetables on the ship. They would rot and die. So they would end up with a vitamin C deficiency. And one of the side effects of scurvy was degradation of the bones. They later solved this problem by carrying lime juice and other products that had vitamin C in them once they discovered that that's what was causing scurvy. Boink. Ah, there's our little man again. Now see on my screen, my picture's over the top of the right side of the screen, so I don't always see where he pops up.
Bryce,
Yes.
I'm still trying to understand the difference between primary and secondary. Is primary like as the osteoporosis as the main disease condition, and then secondary as a result of underlying condition like liver disease? Is that how it is?
Primary is primary is the most common form of osteoporosis. When we see postmenopausal women being put on estrogen replacement therapy or being encouraged to take Tums or other calcium supplements, this is the primary osteoporosis is what we're primarily looking at. It's actually a condition. I mean, it is a condition caused by the fact that their estrogen levels are low, that they're getting older, they may have a sedentary lifestyle, but it's the most common osteoporosis. When you look at steroid therapy, malnutrition, liver disease, those type of things, the osteoporosis is more a side effect of that other disease. For example, if somebody is in kidney failure and they have osteoporosis, the osteoporosis is a side effect of the kidney failure. With primary, the osteoporosis is the main culprit.
Yeah. Okay. Yeah. Thank you.
And Bryce, you said that on your other lectures, like steroids causes the epiphyseal plate to close early. Is corticosteroids like, that's a steroid, right? So would that cause?
Yeah. I have to, and this is a very, very common misunderstanding. There's corticosteroids and there's anabolic steroids. Now, anabolic steroids, anabolic means to build up. So anabolic steroids are those steroids that like Arnold Schwarzenegger and those guys took that build muscle. Testosterone, decadurabolin, things like that. About the only time you'll be exposed to anabolic steroids is if an older male is on hormone replacement therapy. They may be getting testosterone shots, but testosterone is an anabolic steroid. And earlier, you know, back in the 80s, the bodybuilders and the athletes were badly abusing those. I mean, they were taking 10, 20, 50 times the recommended dosage of anabolic steroids because the more you took, the bigger you got. And there were people were having bad side effects and problems with things like roid rage. So that's why they passed a law banning steroids from athletics and eventually just banning them from general use altogether. In recent years, they've found that as males get older, their testosterone level drops. And so they have to go on supplementation. And so they've kind of brought testosterone and anabolic steroids back again to kind of bring their levels back up to where they're back up to normal. Now, that's totally different than a catabolic steroid. Corticosteroids are catabolic, which means they break down tissue. And unfortunately, fortunately, corticosteroids or catabolic steroids, as they're also called, are good at reducing inflammation. And we use them for asthma, we use them for infections. That's when we were talking about osteoarthritis. We give them injections in their back and their knees to reduce the swelling. If you have to take a systemic corticosteroid, in other words, one that you take by mouth or by injection in the arm and it goes through your whole body, it causes a variety of bad side effects. And osteoporosis can be one of those side effects from taking, people that take prednisone on a continual basis every day will begin to suffer some really bad side effects because the corticosteroid breaks tissues down. It doesn't build them up like anabolic steroids do.
Thank you.
A lot of people get confused about that because they're both called steroids, but they actually do opposite things.
Right.
You'll rarely run into anabolic steroids for any reason, unless, like I said, an older male is on testosterone replacement. How to assess, that's really hard to tell. And the reason for that, I don't know, it's in here somewhere. Okay, well, it'll show up eventually, but mostly the bones get weak and they break. That's usually when we find out about the osteoporosis. And also just from the patient's profile. It's going to be a pretty common problem for postmenopausal women over 30 years old. The dowager's hump is when the bone degradates, and it's kind of related to the pain in the lower back. Is the skeletal structure will slowly kind of begin to collapse. I had a picture, but I didn't have a chance to put it in here. But basically, you'll see these older ladies, especially very, very old ladies, and they're walking hunched over.
Bryce, is
Yes.
it the same as the word kyphosis?
Eileen helped me out with this, but I believe the kyphosis is a description of the condition of the curvature of the back.
Right.
I don't think it's the same as dowager's hump.
Yeah, it's a little different. And kyphosis, although I think they can call it kyphosis, kyphosis is just what you see. It's the sign. So you see that humpback, because it can also, kyphosis could also be a sign of other conditions also. So kyphosis itself is just the humpback itself. And I think the dowager's hump is from lack of estrogen. And I think there's other people who have humpbacks. It's due to poor muscle structure or muscle diseases. So kyphosis is kind of the name of the symptom.
I know at the dowager's hump, they talk about they talk about the wedging of the plates of the spine. They began to go like this. They become a wedge, and that causes the spine to collapse. In kyphosis, I'm not sure if that's the same situation.
Yeah, I think they're kind of interchangeable. Kind of like, I'm going to look it up quick.
Also, with the dowager's hump, you also get, with corticosteroids, you can also get a tissue buildup near the back of your neck, which kind of gives you somewhat of a hunchback type appearance. And I want to make sure I'm not confusing those two, because that one is a tissue buildup as opposed to bone problems.
Yeah. I just looked it up. What kyphosis is an excessive outward curvature of the spine, causing hunching of the back. So it's basically, a sign. And I think the dowager's hump, we always put it with older women because of estrogen. There's other people like the Hunchback of Notre Dame. He had other problems, but it still was kyphosis. So that's, and then there's another word called lordosis, and that's, it doesn't curve frontwards, they curve to the side. So I think that's, those are the two main problems with the spine that are signs.
Wait, what? I thought that was scoliosis.
You're also but I think lordosis also. Well, give me a minute.
I think lordosis is with the lower back, like when you're pregnant, and scoliosis is the lateral curvature.
Okay.
So when you're looking at the spine from behind, it curves like this, as opposed to from a side view where it goes like that.
Yeah, my mistake. Yeah, lordosis is more of a curvature, more of kind of a U shape in the back. Sorry, I I was thinking an old guy with lordosis. But that wasn't it.
Yeah, the important thing to remember with as far as osteoporosis goes is the breakdown of the bones with the spine causes wedging. So instead of the spine, the discs in the spine being perfectly parallel as they should be, they begin to kind of crump like this and become a wedge shape. And that's what causes the curvature of the spine. Medical surgical management, labs, you know, it would be nice if we just did a test on their blood and found out their calcium was low or their phosphate was low. That would make life easy, but that's not necessarily the case. Their labs can actually be normal and they still could be suffering osteoporosis. In other words, they still have the calcium in their bloodstream. It's there to help build new bone tissue. It's just not being utilized as it should be. And again, x-rays are a very late diagnostic because we have to wait and see the damage done before you know, we can say, well, yeah, you're suffering osteoporosis.
Bryce,
Yes, sir.
is vitamin D diagnosis for vitamin D deficiency can also be equated to osteoporosis?
Yes, definitely. And I'm
Okay,
not sure if it's in here, but if it's not, I would definitely want to bring that up again. Vitamin D is necessary in order for the calcium to process into the bone properly. And what is another way that we get vitamin D besides supplementation?
Sunlight.
Sunshine, exactly. It also affects your mood, which is why they recommend people who live in Seattle take vitamin D to help elevate their mood. Because during the long gray time period in the winter, when we don't have sunlight, lower amounts of vitamin D can make you rather depressed. So vitamin D is also a supplement that we give to kidney patients to help process the calcium into the bone.
Okay. So you check also for.
You just muted yourself.
So you also check for your vitamin D serum level in your blood as an indicator as a possible osteoporosis or bone condition.
Okay, what was that again?
Meaning, do you also check vitamin D serum level as a possible indicator?
Oh, vitamin D levels in the blood?
Yeah.
Not normally, no.
No, so it's not an indicator for osteoporosis.
A lot of vitamins go through your body into the system into various organs, but they don't necessarily hang out in your blood. So vitamin D levels, a lot of vitamin levels have to be checked by things like skin and hair. They want it. I know naturopaths are very good at that, checking your vitamin levels. They usually use a hair sample because they don't hang out in your blood. They go and they deposit wherever it is that they need to go deposit to, and they don't really hang out in your bloodstream.
Okay, thank you.
One thing I want to point out, probably the most important point of this entire slide, is exercise. There are things that we can do to help slow down osteoporosis, estrogen replacement therapy, calcium, vitamin D, etc. Exercise is the only thing that's been shown to actually arrest and possibly reverse osteoporosis. So, got to get those people out and moving. That's the most important thing. Much like a muscle, if you don't put stress on the bones, they just quit adapting. You have the body is designed to move. So exercise, exercise, exercise. Mineral supplementations, and there, Fernando, we have the vitamin D right there. Calcium, vitamin D, and phosphate in the prescription drug is usually Fosfomax, is a drug that's given to a lot of women postmenopausal to help supplement their phosphate for bone construction. I'm sure many of you have heard of Fosfomax before. And there's estrogen replacement therapy. Estrogen is essential in helping the bone construction. And you'll get more into that with the study of the hormone system when we get to endocrine, which I think you start like right after or next week. Hey, there you go. Nursing management, balanced diet for mineral supplementation. Also encourage them to get out in the sunshine and exercise. Sunshine and exercise. Impaired mobility. Oh, look, there's that word again. And self-care deficit. Osteoporosis, they can become weaker, and they may need some assistive devices if the osteoporosis progresses to the point of debilitation. I think that's the last one. Okay. Any questions on that? Osteoporosis.
What does phosphate do in regards to bones?
Phosphorus is one of the essential elements that's used in the construction of the bone. I can't tell you exactly biologically how that works.
It helps
I heard,
bone construction?
yeah, I heard that vitamin D marries calcium and phosphorus together to make, better bones. So that's what the relationship is with those. Exactly what they do, I'm not sure, but phosphorus and calcium have to work together to build bones, and vitamin D kind of brings them together. So that's how I always learned that. And then when Bryce gets to the urinary problems, when the kidneys go out, many times phosphorus and calcium, even though they're married, they're quite competitive. And if phosphorus starts going up, like drinking too much Coca-Cola, phosphorus starts kicking out the calcium. And likewise, but usually with our American diet, we take in more phosphates than we take in calcium. So that's the problem. If phosphorus gets kind of a handle or it has high levels, it starts kicking out the calcium. So that's for later. We'll learn more about that later. But that's why Coca-Cola is not so great for your bones.
Yeah, there's a calcium phosphate balance. Just like you said, just like, the heart pump uses a potassium calcium pump combination. Calcium and phosphorus work together. But Eileen is absolutely correct. We have usually phosphate shortage is not a problem in our diet. A lot of our soda pops have phosphorus. A real problem we have with kidney patients is because our diet is so rich in phosphates, like potassium and phosphate are the two elements in a kidney patient we worry about getting too high. They go up in a kidney patient because the kidneys are not secreting the phosphorus and the potassium. Of course, high potassium can be dangerous. I mean, it can actually kill somebody. High phosphorus levels are not as dangerous, but high phosphate levels will cause crystallization on the skin, and it causes people to itch a lot. When kidney patients get too high in phosphorus, they itch like crazy because it deposits under the skin. But you'll learn more about the relationship between phosphorus and calcium when we get into the endocrine system next week. Next, Lyme disease. Ta-da! Lyme disease is caused by the tick. The reason that's included here is because this disease can eventually lead to deposits in the joints, causing swelling, inflammation, infection of the joints. So it affects the musculoskeletal system and can lead to chronic arthritis within a victim. But basically, Lyme disease is named after a town in Connecticut where the disease was first discovered and became really prominent. And it's caused by a tick bite. And the tick deposits the bacteria Borrelia burgdorferi. I had it down. I practiced it, and then I couldn't say it when it came time. But Burgdorferi is, you'll also see it abbreviated B. Burgdorferi, is the actual bacteria that the tick deposits in the body. And it can incubate anywhere from 3 to 30 days. And it starts going throughout the body, the blood system and the lymphatic system. And there's several stages to Lyme disease. The first stage is you get a red lesion at the site of the bite. And they call it a bullseye rash because it looks like this. It's red in the middle, white skin tissue around it, and then you get a red ring further. So it looks like a bullseye. And that's why they call it a bullseye rash. That's a dead giveaway. If somebody gets bit by a tick and they get the bullseye rash, you rush them to the doctor. It's not an emergency, but you get them to the doctor as soon as possible and start them on antibiotics. Lyme disease is easy to treat if you catch it early. That's a key message there. Stage 2, if not treated, it can then spread throughout the system, and that bacteria can cause meningitis. It'll be cerebral meningitis within the blood. There goes that Alzheimer's again. The CSF, the cerebral spinal fluid. So it will be a cranial meningitis. It can cause nerve palsy. It can cause peripheral nephropathy, which we are all familiar with our diabetic patients. In stage 3, it could go, if it remains untreated, anywhere from 6 weeks to several years after the infection, the bacteria will deposit in the joints and actually tear joints down, break joints down, and cause chronic arthritis. No, might want to remember that. Medical surgical management. The Western blot assay. You remember that? Last quarter when Bill was talking about AIDS. Bill was back by then, wasn't he? I can't remember. Yeah. I didn't do AIDS, so Bill must have done AIDS, but one of us did, HIV. Western blot assay was one of the tests that they did on HIV patients. But the Western blot assay is a test that can identify the Borrelia bacteria and give you a definitive diagnosis of Lyme disease. Basically, when the bacteria gets into the body, your body's going to launch an immune response. You'll have elevated WBCs, and the IgM immunoglobulin or antibody will be elevated. Treatment is simple. Antibiotics, amoxicillin or doxycycline. There are other antibiotics which you can use if you're allergic to penicillins or tricyclics. If you catch it early, once the damage occurs, we can't reverse it. If it gets into the joints and causes joint degradation, we can arrest it, but we can't reverse the damage that's already been done. Nursing management. Preventative measures, that's the most important thing, especially if you happen to be in community nursing rather than in hospital nursing. Personal protection, wear long sleeves and long pants when hiking through the forests and the jungles of the Pacific Northwest. I mean, it used to be limited just to the East Coast, but it has come out to the West Coast as well. You treat your clothing with plant extract that's called pyrethrin. Pyrethrin, you don't want to use pyrethrin on your body, but you can treat your clothes with it. And what's important is after going on long hikes or going out in the woods for a long time, just check yourself, or if you have a partner, check each other, make sure that you don't have any ticks hidden. Ticks like hot, warm, moist, dark climates. So you will find ticks places like under your arms and in your crotch area is where you will find ticks. Sometimes you'll find them on your ankles or your legs. If you got hot socks, there's a variety, but they're not on the outer exposed areas. They're in the dark, hidden areas where it's moist. Environment. Just keep your environment clear. Don't let the grass grow up over the top of the house. Keep the grass cut back, shrubs kept clear of tall grass, etc., because that's where ticks hang out. Medication management. As a nurse, you just want to make sure the individual is, first of all, if you see any kind of rash like that, they get in and get checked out. And if they get put on antibiotics, make sure they do their complete antibiotic regimen. As you probably all learned in pharmacology, you don't take half your antibiotics and you think you feel better, so you stop taking them. That's when bacteria become resistant to the antibiotic and you create a whole new strain. So make sure they take the complete regimen of antibiotics, and you can use analgesics for the discomfort that comes along with the...
Guys, I have a question.
Sure.
What happens if you said here that if you caught it early, then you can treat it? What happens if you didn't catch it early?
Well, as you saw in the previous stages, some of the damage, let's go back here. If you get meningitis from it, or palsies, or peripheral nephropathy, some of these things are irreversible. I mean, what is peripheral nephropathy? That's a breakdown of the vessels in your extremities. Once they break down, you can't repair. Well, maybe the body can repair those a little bit. I'm not sure. Most people usually don't recover from that. Yeah, I mean, you can arrest it. You can stop it, the damage, if you get treated with antibiotics. But I mean, if you get that rash and you get the antibiotics, you walk away scot-free. If you wait, you can still have some possible side effects from the damage, and you can stop it from progressing, but you can't reverse the damage that's already been done, especially the arthritis, because the bacteria helps destroy the cartilage and the synovial areas of the joints. So you actually get tissue breakdown. You can't reverse that. Yes.
You said peripheral nephropathy is the blood vessels or the nerves?
Nerves.
Oh, okay.
The nerves are a side effect. For example, in diabetes, when people get peripheral nephropathy, it is because the blood vessels, the sugar going through the blood vessels breaks the blood vessels down. So it reduces the circulation to the extremity, which causes nerve damage. So although there is nerve damage, it's the blood vessels that are actually causing that nerve damage. Does that make sense?
Yes, yes.
So yeah, they say neuropathy, death of the nerves, but the death of the nerves is due to restricted blood flow.
Oh, okay.
And
So Bryce, I have a question. So like you said here, stage 3 arthritis. So is it safe to assume that people who have arthritis could also be checked for Lyme disease?
You could. Most people just develop arthritis over time. If they don't have any history of having that rash or having other problems like the meningitis or the peripheral nephropathy, if they're just developing arthritis, it's probably just arthritis.
Okay.
We wouldn't commonly check them, but you never know. You know, in the Northeast, up in the New England area, if somebody is an avid hiker and he begins having joint problems, that's probably one of the first things you're going to do is check them for Lyme disease.
Okay.
I've known a couple people that contracted it, but they got the antibiotic therapy. So, and they were young people too. They were in their 20s. So, I mean, if you're definitely starting to develop joint pain and that type of thing in your 20s, then that's probably one of the things you'd want to look at, especially if you live in the Northeast.
Thank you.
Sure enough. Any other questions? I think that is all I've got. I'm going to stop the recording because we've kind of gone over time on the recording.